So good morning. We'll be getting started in about 1 minute, but while we're getting started, we'd love, now that we're all friends and been around each other for quite a while, we'd love to know, what is your biggest pet peeve? If it's me, you can just private chat me if I'm your biggest pet peeve. If it's not me, I would love to know what kind of grinds your gears. So personally, Chelsea and myself would know to avoid that at all costs, so to speak. So, but we'll be starting in we'll give people about 2 minutes to kind of get on as we start to trickle in a little bit. What is your biggest pet peeve? Maybe you don't have any pet peeves. I'm sure you do. I'll tell you my biggest pet peeve, and my children know this, and I may have ruined their childhood, but I absolutely cannot stand balloons, especially the ones that people like when they rub against them with their hands, and that sound that drives me absolutely crazy. So I do not like balloons. So if you ever see pictures of my kids' parties, you won't see any balloons at all, which gets them upset a little bit. But I can stand a lot of things, but I do not like balloons. I don't like balloons popping. I do not like balloons being touched. I don't like any of it at all. So Azra, biggest pet peeve, not keeping your word. So hopefully, Azra, I've always kept my word with you. Tamana says chewing gum. Wow, Tamana. So Tamana, is that seeing people chew gum or just the idea of chewing gum in general?
The idea of it in general. I just never understood it.
All right. A lot of things around eating. Eating with your mouth open, loud chewers. Chelsea I think you had a story about your brother used to do that on purpose, right? At the dinner table, he would chew loudly just to irk you.
He would. Right when I would begin doing homework or studying, he would just start chewing loudly. And you'll sit right next to me too, so it's the only thing here for hours.
Oh, okay. So Kathy says, saying you should, as if, okay, I can see that. You should do this, you should do that. That's what my mother-in-law does to me. It gets me upset too. Seth agrees with you should. Lisa from New Jersey says using cell phones during professional meetings. Is that just texting? Is that looking at social media? Is that actually getting on your phone talking, or all the above? I'm guessing, Lisa.
Mostly just texting. That they're not paying attention to the speaker. They're on their phone. Their head is down and they're on their phone.
I'm sorry. What did you say? I'm sorry.
I said they're.
I'm not joking. I have my cell phone up on my screen. I'm just messing with you.
You got me.
Hey, Shameka, you got a pet peeve?
Well, I try not to have those, and that means I idolatrize my own emotions over somebody's actions.
That's fantastic. All right, well, let's keep them coming as we begin our State of Solutions team webinar. Our subject today is stakeholder engagement. I'm so happy that Shameka was here today. Because I may call on her for one quick second towards the middle. So she is the group guru of stakeholder engagement and the author, one of the main authors of one of the reports I wanted to share. So maybe she'll have some feedback on that report towards the middle of Today is January 17th, and we'll get started. Our agenda today will, as always, we'll start off with a quick reflection. We have a unique reflection today. We'll just have a round robin, any updates from any of our states, any questions that you may have about stakeholder engagement that you would like to have answered before this call is over, or just any other statements you would like to make while we're in this group setting. We're actually going to flip that. We're going to have Maine go with the state of the states, and then we're going to look over some stakeholder engagement material that many of us have filled out, just to familiarize ourselves with it, or maybe update we may have, especially as we're leading into our Equity Action Lab season. Our guest speaker today will be Dr. Amy Bugnick, who runs a health coalition in Summit County, which is a county in Akron, Ohio. She's done some great work around community health workers, which I know is a subject that's near and dear to a lot of us on the call. Then we'll have our survey, some updates, and then just some aspects of the team. How's it sound? I'm going to mute everyone if I can, or if you could just self-mute, that would be great.
Yes.
Okay. I think that was my friend Rose. I think I was able to mute Rose there. All right. All right, let's get started. So these reflective passages are from a equity concept paper that was written by many of us in 100 Million Lives. Just, just how we see equity in our world and how we view it. It's a paper that I will send back in our email. It was written, I think, about 2 years ago, and it's still relevant. It's still very relevant now. We've actually updated here and there, but it really holds relevance. So these are just 3 of the passages from that. I will ask if someone will volunteer to maybe read the first one. Okay, I'm looking at Osra. So Osra, do you volunteer maybe to read the first one there if you can?
I can do that.
Sure.
Thank you. What often holds us back is our belief that these problems are too big, too complex to solve. If we were alone, that might be true. However, people in every community are trying to address equity, often in silos. By bringing our pieces of the puzzle together, we realize we are far more abundant in resources and solutions than we imagined.
How about Lisa? Can you do the second one for us?
Sure. To dismantle the system and structural factors necessary to create equity, we need to develop an unprecedented collaboration across sectors and with the people with lived experience of inequity. To do this, we need to develop trust, skills of collaboration, sharing of assets, and community capacity to contribute to the solutions.
When we approach this journey towards equity, recognizing that we are interconnected as a human family in a global community, we realize that, I'm sorry, something is cutting us off here. We realize that the unleashing of trapped and untapped human potential benefits us all. So let's take a moment just to think about that. Maybe chat in some feelings, or you can even take yourself off mute or just speak up about how this resonates with you. And we'll be silent for a few minutes. Once again, to all our friends who've just joined us from all over the country, I'm recognizing a lot of names. Some of us are being snowed in right here in the Midwest, but we're warm with each other. You like that, don't you, Shemeka? That was pretty good, wasn't it?
Absolutely.
We're just going over some reflective statements that were written in an equity concept paper from a lot of leaders within 100 million healthier lives. I will send this paper to everyone after the call with the standard overview email. But just looking over these statements, it reminds me of a quick story. Before I joined IHI and I was doing social service work in Chicago, I was asked to join this advisory committee that was like the who's who of health professionals in the Chicagoland area. And we met sort of like an action lab. We met for a day and a half at the Cook County Department of Public Health. I mean, it was everyone you can think of except the people that was most suffering from disparities and the people that were really close, the people that was serving people that most affected by disparity. And we came up with this idea. You know, we had we had a few aims, but one aim that we wanted to really enact was the fact that we wanted to enforce law. But I'm going to try to mute some folks here. We're going to enforce the law that that if you are living in a HUD-funded senior home, you could not smoke inside, around, or even in your apartments. We didn't have anybody that lived in any of these homes. We didn't have anybody that managed any of these homes in this meeting, but we came up with this policy. And I thought, you know, that I would immediately take this to one of the managers of the senior home that was, you know, in my service area. Her name was Billy, beautiful person. She and I had a great relationship. And I was going to, you know, show her this policy we enacted, and knocked on her door, and I sat down, I told her, and she literally laughed in my face. She was like, we have issues around illegal gambling, prostitution, drug use. And she, all the litany, you think I'm going to like now go knock on people's doors and tell them they can't smoke in their apartments? So I was like, I just wasted about 200 hours of my life because we did not involve the people that were really close to the situation. She was like, if you'd have had me there, then maybe I would have been motivated by what you were saying. Maybe I would have seen a better way. Maybe I would have given some ideas. We came up with a better policy for us to go knock on doors and tell them they can't do it. So I'm saying that all to say that these words really ring true. And it's often hard to do, but if you don't do it, you're not going to see the transformation that we all, you know, the reason why we joined all together back in May. We're still not going to see that if we don't really, truly have stakeholder engagement. Anybody else want to have anything to add before we move on to our friends from Maine? All right. I'm not saying
it. The paper itself is a great asset, so I'm glad you're sharing it. And it just rings very powerful, especially the guiding principles that is located in that document as well. Yolanda and I just recently converted them to ways of action and included another principle from some lessons learned that Shoma shared. So definitely a good asset and resource. Perfect.
Thank you, Shameka. All right, so we have Kathy, who's going to give us an update on their journey of stakeholder engagement. And it's an exclamation mark, so I'm going to say States of Solutions, Maine!
That's right. That reflects on our level of enthusiasm around the work. So it's a really fine, we really were grateful for the opportunity to be involved. And let's see, shall I just tell you when to advance the slides?
Yeah, I'm here at your service.
Perfect. Excellent, and I'm glad to see that we have one of our colleagues, Fran Mullen, on the line too, so thanks, Fran. We came to, the SOS in Maine grew out of actually some really outstanding scale community work that was happening in Waterville, led by Fran Mullen, who just came on the line, who's the executive director of Healthy Northern Kennebec, a community action program, actually not technically a CAP program, but a quality improvement initiative area in Waterville, one of our cities in central Maine. And when there was the plan to scale up those programs to statewide programs, there was people were looking around for folks that would be able to pull together a wide range of leaders across the state, and had really good connections, particularly with groups of individuals with lived experience, and in the healthcare sector. And that led the Maine Health Access Foundation, our major health funder in the state, to reach out to the Hanley Center, where I work, which is the Hanley Center for Health Leadership. Our work is our mission is to inspire and grow collaborative leaders to solve today's health problems, and we do that primarily through leadership development training in all different parts of health and healthcare across the state, and as well as bringing people together around complex problems that require a collaborative solution. So this was a really nice opportunity for us to dive in, and we have done a significant amount of work in health equity in Maine as well. Just a couple of things about Maine as we're getting going, and maybe we can go to the next slide. In Maine, we are I think the whitest state in the country, and also the oldest state in the country. And so many parts of our state don't have a lot of racial and ethnic diversity. We definitely do have health equity challenges in those areas, and poverty and substance use disorder and various other areas. And there are some areas in the state where we have cities and localities and communities have been very welcoming to immigrant, refugee, and asylee communities, and so particularly in the greater Portland area and in the greater Lewiston area, there's a significant populations of people of color, and as well, we have a number of tribal members who are spread throughout the state, and also have some tribal lands here in the state. And so the tribal communities are ones that are definitely experiencing health equity challenges. So as we were looking to pull together a collaborative that would be working on improving health equity statewide, we reached out to a wide range of different partners, and here are some of those that are the logos and all there. If we go to the next slide, we'll see the more specific information on each of the organizations that are involved. And with our coalition, we have, so next slide. With our coalition, there we go. With our coalition, the participants fall into three major groups. One is composed of a lot of ethnically based community organizations, and also organizations that work closely with folks who are from immigrant refugee communities. We have some organizations that are just committed to healthcare improvement across the state, and as well, we have a couple of involvement from the state with the state Centers for Disease Control and Prevention, as well as the City of Portland Office of Minority Health. I know that many of the groups involved in SOS, the CDC, or some part of the state health department is a major leader in the coalition. And when we were getting this going, our state state health organizations had not much capacity and not really a lot of interest in the topic area, and so weren't really in a position to take on a leadership role. We've had a recent change in administration, and that may be changing, but we were very pleased to have some strong personal advocacy, and we're grateful that the state allowed one of our folks to be engaged and involved and keep us connected on a statewide level. So the people who are listed here are all of the different organizations that are involved with us, and we have a couple of more that have come on since that time. So if we can move to the next slide, we'll just get a little visual of different ones of the partners along the way. And then when we gathered the group together, we were initially thinking that we would focus on a particular topic area that we knew had some general application across many groups of people with lived experience with health inequities. But then we ultimately decided that it would be better to pull the group together and to have the group decide what would be the best way to move forward. And that, to some extent, guided our early involvement of people in this collaborative. We rather intentionally didn't really include at the early stages the health systems, which we see as a significant partner in this work, but we wanted to hear the voices of people with lived experience as they were deciding, what should be the directions that we moved. And so, next slide. With that, we developed a shared vision, and all of this, of course, is actually a part of our storyboard. So we wanted Maine to be a place where healthcare organizations regularly engage and care for people with lived experience of health inequity with culturally sensitive care, and recognized that that as Drew's earlier reflection points pointed out, that trust is a significant component of that, and so we pulled together a passionate group of leaders to work towards that. Next slide. Again, a few more pictures and all there. And next slide. We moved then into a rather lengthy aim statement. The topic area that the group identified as a common challenge across the state, that all of the populations and groups that we were working with thought would be useful to do some work around, was to strengthen the cultural humility and proficiency of healthcare organizations around the state. And we decided to do that by engaging and convening some senior leaders from healthcare organizations, along with community members, to allow for the community members to tell stories of their experience within the health and healthcare system, to not only present data, but also to present, to give the heart stories that we hope and expect will engage the senior leaders in a way that will then encourage involvement in health equity work and bringing greater health equity strategies and training within their organizations from the top leadership across the way. So we will be working on getting at least 3 leaders to commit to pilot at least one cultural humility promotion strategy in their organizations. Next slide. And again, just a few more pictures from Maine, including Margaret Chase Smith, one of our historic women leaders in standing up for things when times were tough in the McCarthy era. But moving on to the next slide. We decided on this focus area because we were hearing from people with lived experience organizations and people that work closely in those communities that it was not uncommon for people to be going to healthcare providers and not being treated in a way that was culturally sensitive and was conducive to enabling those individuals to be able to take on their own healthcare in ways that worked well for them. And so that oftentimes leads to people not being able to take care of themselves well and to access resources and to be able to be healthier, and as well sometimes leads to people just not seeking care when it would be helpful for them to do that. So that's the why behind the area, why we got into the health cultural humility, and so we're looking at building ways to promote that going forward. And so the next slide, just one of those infographics that we like, and then final, next slide. Just contact information, and then Drew, I want to go to the equity, the stakeholder engagement plan, because that's we were asked to talk about a tool that we used and are using that would be that was helpful in terms of organizing ourselves as we're looking and moving forward. So we used the stakeholder engagement plan as we're pulling together things for our phase 2 application, and our team, our partnership group is coming together tomorrow, and we'll be really diving into taking more action on the engagement plan.
Thanks for stalling,
There
Captain.
we go. Okay, here we go. Hey, yes, excellent. Thank you. So if you can, yeah, that's perfect. So we really followed the framework that was set out by the tool, and really brainstormed who were some of the stakeholders that would be really helpful to try to pull into our work to accomplish our aims. We identified the hospital association. Looking at, for each of them, where they are, where it is that we have our collective team has common ground with that organization, how we wanted to engage them in this work, how we planned to get them engaged, and how frequently we thought we'd be in contact with them, and how who exactly among our team members would be involved. And I will say, as I look at the overall engagement plan, who will be responsible, we're expecting tomorrow to flesh that out more thoroughly. But we thought that the Hospital Association, because of their relationships with hospitals and health systems around the state, would be a good partner. The Hanley Center, because of our work with healthcare organizations around the state, we've been doing that work for 10 or 15 years and have been training leaders around the state. So we have some good connections, and so but we haven't really worked with the Hospital Association around the issues of social determinants and health equity to a significant extent. So we're going to reach out to them and looking particularly for them, once we get a little further down the line, to look at expansion and scaling up after we do some initial pilot work. If we can move the slide up a little, not quite, yeah, there we go. Thank you. The Maine Primary Care Association is the organization in the state that works with federally qualified health centers around the state. And Maine is a significantly rural state, and by New England standards, it's a large state, not a large state by Midwestern standards, but we do have a significant number of federally qualified health centers, and we thought that those would be a good folks to engage in this work as well. And we actually have already brought in the executive director, Darcy Shargo, who's now on our planning team. You can slide down a bit. We, as with Hanley Center's work in leadership development, we integrate health equity content into all of our programs, and we have a significant relationship with our alumni, and so they're a natural allies for us. And so we are, again, looking to reach out to them to engage people that are passionate about this work. A number of the people who are on our planning committee already are alumni of our courses from ethnic community-based organizations and others. And a number of those organizations as well have significant numbers of community health workers who will be instrumental in the engaging people with lived experience in our convening. Down a little bit more, we've got, that's good, where we have connections with various leaders from some of the healthcare organizations. And again, those are some of the key people to be hearing the content and then agreeing to engage. And we hope and expect that some of the leaders that we've indicated will come along with people from their staff that would be the on the ground people that would be involved in, working with people with lived experience to develop cultural humility related trainings or expand or tailor work that's being done. And then the largest category of folks that we consider essential in terms of our stakeholder engagement are members of our community partners with lived experience in their communities, and looking at how they can really be involved in identifying people with good stories to bring to the convening, and to be people that will be resources for, direct resources for the healthcare organizations once we've connected people across the board. So as I say, tomorrow in our meeting, we're planning to dive into this even more. We're planning to hold the convening in March, and to come out of that with a lot more data, a lot more engagement, and a plan for piloting within healthcare organizations across the state some good new health equity and cultural competence work. So that's what we have to say. And
thank you so much, Kathy.
Yeah.
That was really excellent. Is there any questions? I didn't see any questions in the chat. Does anyone want to have any quick questions? Maybe people are not so much struggling, but starting to adapt their engagement plan as they go into the action lab. Maybe it's the first time you've seen one before. Maybe have some questions on how that looked, or maybe some some potential outcomes that they may have. So one question came in, Kathy: was St. Mary's Hospital in Lewiston approached to join as well?
We do anticipate that we would be working with St. Mary's. St. Mary's is actually a well-known partner for us in a lot of work, and are, to be honest, I think a little bit further down the line in some of this work than some of the other major hospitals in that area, which is part of why we're reaching out to the other hospitals. And we will be looking to work with St. Mary's as well. Yep.
Any other questions? So just chat them in if you have. Okay, we have someone come in. So Priti said, when engaging people with lived experiences, how long did it take you to build trust? Wow, that's a good one.
Yeah. Yeah. Well, it took about 3 weeks. No, I'm kidding. I think that we at the Hanley Center sort of see ourselves as something like a backbone or organizer in this work. We were well positioned because our leadership development courses, we work with people and intentionally bring in people with lived experience into those courses, and we work with them for months and sometimes year-long courses. So over the course of, and a lot of our work is around building trust and relationships through that work. And so, as I said, some of the leaders who are involved in this are alumni of our courses. So we have long-term relationships with them that are based on trust, and then they have relationships with people in the community that they can engage with that. So that explains how we did it, but I know that it will depend a lot on the communities themselves, the people that you're working with, what kind of experience they've had with the organizations and people, what kinds of trust challenges they have to work through. And so I think that it's a really variable, that my answer would be it's pretty variable, but I'd invite others to, I certainly am not the authority on the answer to that question.
Yeah, I would love to actually stay with that for a second, because I think that's a really, really key point about trust. And I would encourage others on the phone that I'm sure a lot of us are dealing with that now. A lot of times we talk about engage people live experience. It's not a new idea. It's been done, but it's been done in ways that's been so ineffective. And you've burnt people, and you've lost trust, and you've brought people to rooms, and you've done bus tours and things like that, where you've embarrassed folks, and or you brought them to a room for hours and never actually talked to them, or had your community health needs assessment and then just shared it with them and then left, and then really talk about any solution. So this has all happened, and this is all have this cut away at this trust over years and years and years. So I would love to hear other stories about trust issues that folks are having, or if you already understood that trust was a problem, things you've done to kind of build that trust back up. I would love to hear, if possible. Not just, people like Shemeka or Seth, anyone else that has had to kind of build that up in their work. I would love to talk about that for a second.
Hey, while people are thinking, I can certainly share some experiences in when you have several silos working with communities that are all having the same target community, but they aren't communicating together. And more specifically, this even happens with learning institutions. They're different departments with different research focuses that are going into the same community. So building trust in those spaces, it first has to be internal, like having that understanding internally with the institution is helpful before they get out into the field, and then allowing for that space to be repaired and there be some listening sessions solely just to hear that the healing that needs to be needed. It's really hard to put a time to it, Preacher, because every community is going to be different, and a lot of community members are challenged and upset and really want to be heard. And you can't put a time stamp on it if that wasn't in your outline of your planning before you begin to engage, because that's where it has to start when you're talking about building trust and giving that free space. Though your organization or institution may have had nothing to do with it, because no one has cared to listen, they're going to give it to anyone that's coming. Those are some thoughts that I've had with my experiences.
I think that's why when we have this forum, we talk about competition, not competition of as a form of how we think competition. It's folks that are doing the same work that we've done in the past, have been competing for the same dollars. How do we now form a coalition? So maybe we won't get as much dollars, but everyone will get a piece of the pie. And now we're all sharing data, we're sharing resources, we're sharing people power, we're sharing ideas, we're sharing space. And now we're actually accomplishing some of these some of these aims that we set out for that, have been eluding us for generations, so to speak. So that's why this is another part of that forum where we ask who the constituency is, who's the leadership, who are your supporters, but also who's the competition, and even more importantly, who's the opposition. Like who, no matter what you do, will always oppose it. It could be that one person that comes to the school board meeting, and we all know that person is, no matter what is said, they're against it. We need to know that too, right? Thank you so much, Shamika. Seth, I think you trying to say something? Okay, I think Seth chatted in here. We got some great chats. So Ashley from Cattaraugus, New York. For working with older adults as a younger person, trust has been created by closing the gap between what we say we will do when we meet and to when it's actually completed. Ashley, can you elaborate on that a little bit if you can? I don't know if you can speak or not. If not, that's fine. And then Seth, in our journey of engaging those most affected, our health department, that's Maricopa County in Arizona, our health department has relied on organizations who have built relationships with community members. It's great. Those institutions have been crucial to bringing people together to grow trust. At the beginning, those meetings consisted of institutions listening only. I have a lot of stories about just listening and not actually involving yourself in the conversation. A lot of it is out of fear, right? I had a great conversation with a top official in the health department recently, and one of the health departments recently, that said that a lot of times when we go to these listening tours or we go to these advisory groups, health departments officials stay quiet, not because they don't want to be in the conversation, just because of what they say may be misconstrued, or they're fearful that they may say something that makes people feel like they're going to like throw money at a situation or anything like that. So they stay quiet out of those reasons. And I think, like, how do we combat that, Shameka? Like, how do we kind of cut away that fear? Because maybe it's not all on the people we're engaging. Maybe it's something we got to work on internally too. What do you think, Seth? I'm sorry, Seth. What do you think about that?
Hey, Drew, that's a great point, and I don't know, because I feel like that is a constant conflict that we're facing with our institutional leaders and with our institutions coming into the space of the community and asking questions. We have to be really careful walking the line of just being really transparent and saying, like, we're learning and we trust that you have the answers. And we're probably going to mess up, but please go along in this journey with us.
Drew, can I say something as a community-based organization?
Sure. Is this Ashley? Yeah.
Yep,
hey,
it's Ashley.
Go ahead.
Hi.
Please.
In terms of our older adults, some way that I found is that I do have to speak up. And if I've made a communication error with another organization that they're also working with, I kind of have to fess up and say, you know what, that's my issue. I should have communicated them before what we were planning to do, making those changes, because now they're kind of taken aback by it. And I think they appreciate that, knowing that we make issues internally and that we have to fess up. Like, you do kind of have to choose a line sometimes.
That's an excellent point, Ashley. That's really good. That's an excellent point. All right. Any more comments before we move on? I want to just ask really quickly I don't know if Amy has joined us yet. Amy from Akron, have you joined us yet? I know she's going to be joining from her car. Okay. All right. Well, we have some more comments before we move forward. So Fran from Maine is saying, working on true systems change statewide. Folks in Maine are hopeful for increasing health equity. Thank you, Kathy and the Hanley Center for Leadership. So there is hope, right? which is always a great start. Thank you so much. So I'll also send out this engagement plan template. Thank you, Kathy, for kind of going over it. If there's any questions, we'll obviously have office hours around stakeholder engagement next week. I think I'll be probably facilitating it because a lot of our friends will be at our one of our was it biannual or semi-annual meetings in Puerto Rico. So I will not be attending.
Yes.
So I'll take on the role of facilitating that office hour next week. And before we get going, all right, thank you. So a lot of kudos for you, Kathy, and thank you once again. I did want to share another document that I think is that I should have shared a long time ago, and I didn't. And I'm glad Shemeka is on the call because she's one of the authors of this document. It's our Scale 1.0 Synthesis Report. It was written in July of 2017, and it's engaging residents with lived experience, right? And it was co-authored, like I said, by Shemeka, but co-authored by so many of our community champions. And maybe Shemeka, you can just give us that term. It was actually co-authored by our guest speaker, who should be coming along pretty soon, hopefully, and others who are people with lived experience, who are people who work directly with people most suffering from these disparities. And they wrote this report. So if you don't mind, Shemeka, can you maybe just take us, maybe highlight, if you can, some of the things in this report that people should look for as they're reading it?
Absolutely. Thanks, Drew, for lifting up this awesome tool. And in addition to the census report, I don't know if you'll go into it here, but there is also a reference to Live Stories, which is a virtual toolkit that kind of addresses a lot of things that we learned as far as best practices when it comes to engaging community members with lived experience. You can scroll down a little bit. Something that I would definitely highlight is looking at not only the authors as allies to find their stories. There's videos. There's also YouTube videos. There are PowerPoints that could also help you help support the work in how you begin the journey, no matter where you are. But going down, some of the things that really stood out that we saw kind of hindsight was our growing our community champions to steward other champions, which was kind of the journey that I ended up coming on. But this kind of shows you another avenue of what's possible in not only how you're growing your engagement, but also where they could go. So you're planning not just for the time stamp of what your initiative is, but long after, so that this initiative that you're beginning to co-design with these champions can live sustainably more strongly in their community. So there's going to be a lot of information around recruiting, integrating, and engaging community champions, as well as growing their leadership as well. So I'd say this is a good read, an absolutely good read and reference to be able to point back to kind of get the science, especially when it comes to the framework of community solutions and how pivotal and significant having those foundations in place and the habits of the heart all work together in bringing everyone together to be able to produce this. So I was very happy to serve alongside a lot of the champions and hearing their stories, and we were able to compute that as data supported, as well as giving an overview of how people can get engaged. And so we kind of, based on the level of engagement, and it could vary from someone being involved in focus groups to someone being involved in an action team. And we kind of help organizations and institutions self-identify and then see where they want to go. So seeing where they are now and seeing opportunities to co-design growing leadership in others as they see themselves integrating into your work in the community. I guess I can pause here and just to see, is there anything that's resonating with anyone, that's kind of sticking out, that I can tell you if it goes in depth here, or you can find it on Live Stories. I would definitely say Live Stories is going to be another asset and tool, because you're going to be able to actually see the data, you're going to see what we were finding, you're going to see the lessons learned from a lot of the champions firsthand, whether it was a community champion that was also serving as a local improvement advisor. And we identify community champions, just to be clear, as a person with this experience facing inequities that is also serving in a leadership role in their community. So they could be a liaison, they could be a networker, they could be a community health worker. but their lived experience is also the narrative of maybe a collective voice of the narratives within that marginalized community. So we identify those that are growing their leadership in that capacity as community champions in this community solution framework. Some of the things I think will be very powerful to bring out and share is around the community health improvement and the policy making and governance, because this, you'll see a lot of these things will align with your overall work and what you're trying to do in communities with engaging, whether it's your statewide stakeholders or even digging deep into your community organization. So there's going to be a variety of content that will support your journey and help you co-design what's next. With that, I am complete unless there's some thoughts or questions.
Like I said, I think I would ask that everyone, when they have the time, especially if you're going to be snowed in this weekend like myself, to maybe go through this this document. It was, like I said, it's really well written. It was primarily authored by Shemeka, and Shemeka's a former colleague. She's still colleagues of ours. Her name is Ziva Mann, who was a patient ambassador for Cambridge Health Alliance in Boston, who has navigated the healthcare system better than anybody that I know, and really added some great information to this document, along with, like I said, the dozens of community champions, people with lived experience. So I think it's one of the a hallmark document. So I think that once you guys go through it and maybe highlight some things, definitely bring some questions to our office hours next week. We'll definitely have them answered. Like I said, a lot of this stuff is truly trying to lead us into our action lab. Maybe make the action lab a little less, I won't say intimidating, but the Let Her Know Action Lab is something that we don't have to over prepare for it. I've said this a few times. We have the people who we need now. And it's all about getting us into a room and really talking through some solutions, and then doing a rapid cycle improvement on it, and then building it towards something even grander going forward. So yes, Jana, this will all be sent in our email that usually comes out later today or tomorrow, a paper form of all this information. All right, let me see. I'm gonna, hopefully our guest speaker has joined us. Amy, are you on the call as of yet? I don't see a phone on there. She may not have joined us. We may have to just jump ahead, and hopefully she'll join us at the bottom of the hour. So Chelsea, I think maybe we should jump to the let me jump to the survey real quick, and then go over the survey. We'll go over the results of the survey. Amy says she is coming. Okay, she texted a second ago. Okay, so let's maybe just jump to the survey and then go over the results of the survey, and then by that time, I think Amy will have joined us for our guest speaker, and then we'll probably end our day a little early today. All right, so let me go to that slide real quick. Give me 1 second.
Thank you so much, Drew. And as you pull up the slide, I'm going to drop the survey into the chat so individuals have a few moments to get started on it while I explain what it is. Great. So as most of you likely know, we regularly try to survey individuals on this call series just so that we can know if the conditions that we give are useful and applicable to you all. As you can see, our January 3rd numbers are a little lower than usual. Sorry, the rating was a little bit lower than usual. We kind of got in at knowledge gains at 2. around 2.5 for the value of session, around a 3 for practical application. But overall, our survey results are increasing. So more and more of you are taking it, and we really use the data and information that we collect during these surveys to improve the quality of the calls overall. So as we wait for Amy, we ask that you all just take a moment and fill out this survey, and it will really help us gain data on how to apply this information moving forward. Drew, would you like to go to the next slide? Or do you think, oh, well, maybe we can hold on, ask them all first.
Yeah, let's let folks just fill out the survey. Give them about 2 minutes or 3 minutes to fill out the surveys, and then hopefully Amy will be on by then.
Sounds good to me.
Hey, Drew, I'm here. I just sent you a note.
Oh, hey, Amy. All right.
I was driving and I had to get to a safe place.
Oh, yeah, please do that. All right.
I figured you didn't want that on your conscience.
All right, we'll get started in about 3 minutes, Amy.
No problem.
All right. How do I introduce Amy Bugnick? Let's see. If you look on Facebook, you'll see that she is a fun-loving, great mother who really loves her community. If you see her in a business setting, you would think that she's the smartest person in the room, that she really has her fingers on the pulse of what true health and well-being transformation means, especially in communities of concentrated poverty. She leads she's one of the leaders of a fantastic coalition in Summit County, Ohio, which is the county of Akron, the home of LeBron James. She recently just finished her PhD. But the knowledge she's brought to our team over the last 4 years is second to none. I call on her a lot for advice and information, and she's always a willing collaborator with that. And I'm happy to share her with you today. I think one of the hallmarks of her, in my opinion, of her work in Summit County has been her work with community health workers, and how she's advocated for community health workers, and how she's really shaped how their knowledge, their direct influence in the community, and what they've brought to her coalition and to the health department and Summit County in general has been second to none. So with that, I will turn over to Amy to tell us all about community action and the Pathways Hub of Community Action in Akron, Ohio. So Amy?
You're too kind. If people met me in person, they might describe me differently. Welcome, everyone. Thanks so much for the opportunity. So I spoke with Drew, and he shared that you all might want some information and sharing about our experiences with community engagement. So just a little bit of background. I am a public health person at heart. That's what my PhD is in. I've worked multiple years in different public health settings. And when we had the opportunity to develop our Pathways Community Hub, which I'll explain what that is, I had the opportunity to then move to a nonprofit within the county, but still work extremely close with our public health entity within the county. So it's great to be among my people. And so I have several slides, and I hope that if there's opportunity, if there's questions or, insights, thoughts, I would love to hear what your reactions are. So Drew, you're gonna manage the slides, right?
I got it.
Okay. So we started our journey when I was at Summit County Public Health, and we have multiple home visiting programs. We had lots of dollars that were invested in infant mortality. And in 2013, Ohio had the worst Black infant mortality rate nationally. And so there were lots of conversations and lots of groups that were getting together, and we had some investment from the state health department to develop what were called Ohio equity teams. And we took a deep dive into our data, looking at it by race, by socioeconomic status, by zip code, by hotspots. And we kept coming back to the same place, that we had some families who had like 10 and 12 case managers, yet we weren't seeing any movement in our numbers or within our system to have any kind of change in our outcome. So we started researching models, and we looked across at health leads and help desk and all of these other types of community care coordination models, and we came across the Pathways Community Hub, which is actually about an hour south. The co-developers live about an hour south of Akron. And what we ended up doing at that point, we made the decision that this makes sense. However, we've got all these partners at the table, and they're the ones that would need to work with us and employ the community health workers. We've got to have these community meetings. So we went one by one to our partner agencies and said, look, we think this is a good idea. What do you all think within the realm of your work? And it ranged anywhere from like hospital systems to faith-based organizations. And then we gathered a community meeting where we had them come and present the model and really explain how it would be a level of innovation and enhancement to what we were already doing. So everybody voted, and we decided that this made sense. And this is probably the first time this ever happened in my life, where we actually, at that point, after doing a lot of planning for several months, a grant application came in front of us, and we said, wow, this is a great time to solidify partnerships and really get buy-in. I don't know how many of you have ever done wow, there's a grant, let's get some community engagement, let's pull people together, okay, let's write the proposal, and then we'll figure out the rest. That has happened to me more than I can count. And so this felt like a new opportunity. Next slide. So what is a hub? A hub is actually an evidence-based care coordination model where my entity, which is Community Action, we're the backbone fiscal administrative agent of the project. Not only do we have contracts with the agencies that are providing the services directly and employ community health workers, we've developed this network where we're doing the training of community health workers, and we've also leveraged Medicaid managed care contracts. And it's through those contracts that our member agencies can bill for the services of community health workers. And what's really, really interesting is that this is probably the first time in my public health life that we actually were looking at risk factors from a social determinants perspective. typically it's about outputs or how many home visits or how many interactions you had with families. This model uniquely looks at, did they get housing? Did they get to the doctor? Did they have the support systems? Did they have developmental screenings for their children? And the payment points are directly tied with those outcomes. The other true innovation is that we share a data system amongst all of our partners. So everyone that is contracted with us and has community health workers share a data system, which again reduces duplication and is giving us lots of information across the system about challenges. But I would say my favorite part of the innovation are our community health workers. Not only are they most dynamic people that I've ever worked with, their insight and commitment is like no other that I've ever experienced among a workforce. They bring their lived experience. So about 90 to 95% of them have had their own experiences, not only navigating through benefits and systems and or having had either themselves or a family member who's lost an infant or has had a very, very medical fragile child. So their sort of innovation to our model is that they're connecting with families at a very different level. And what's been very, very interesting is the voice that they're carrying, not only for their families, as well as themselves. And so when we think about all the opportunities to get engagement and feedback, you know, I'll go to them and say, hey, I made this like resource list. They're like, Amy, nobody would put it together like that. That just doesn't make sense. And it's been the most insightful and helpful piece. And I think as people were recognizing the value that they were bringing forth, there was also some shifts that had to happen in terms of power, in terms of adding different voices to a healthcare team or within an organization. And what we started to find, and what probably my largest platform has been, is that we're not going to do a drive-by feedback. You can't ask somebody to kind of dance in and out of the circle of input. If you're truly not going to include them in our co-design or our feedback, then it's not fair to have them just give feedback when you feel like it. And so we've really made, or at least I've publicly and others amongst us have said, we need to start to add their voices for community engagement and feedback on advisory boards, on work groups, on strategic plans, because if you really want something to work within neighborhoods, they really could carry the voice and bring families that would give us that insight, which again is a very unique opportunity, because we would always, you know, run around think, oh, we've got to have these community meetings, we need these community forums. And now we've actually got paid workforce who are the pulse of the community that can bring us that information. Next step, or next slide. I just wanted to share that the Pathways Community Hub, if anybody's interested, we're one of 10 certified nationally models within the country. So if you're interested and want other information, I'm happy to share that. But these are some of the other hubs across the country that are doing this kind of work that we're replicating and sharing as well. Next slide. This is actually a very theoretical view of what the hub looks like. So we're in the middle, we're the Pathways Hub Community Action, and the colored circles on the right are all of the different buckets of partner agencies that have contracts and employ community health workers. And at the top, that's where the money funnels in, the resources that we're then distributing back out to the agencies. And so you'll see on the left side, for those of you who are probably very familiar with social determinants of health, you'll notice that there's a deep connection between the work that we're doing and also addressing the social determinants of health to have actual true health outcome change. Next slide. These are our families of community health workers who have come and been trained and are working in our county. Several of them are working in surrounding counties and came to our particular training, but you can see not only I feel the enthusiasm through their pictures, but also the levels of diversity that exist within our groups. Next slide. So when I think about, you know, the tenements for community engagement, and I kind of touched on this, we really have such an amazing opportunity to have the voices of our families and community members through our community health workers. They truly have the pulse of what's happening. And they're so interesting about meaningful engagement and getting input from, not only who they're working with, but also through the systems in which they're working with families. And if we think about, opportunities for policy change and system change, they really are a great catalyst to help us do that. I think another sort of aha moment that my colleague, who's director of population health at the health department, they have such strong epidemiological support and data and infrastructure and do very robust community health needs assessments. And when we sat down with some of our community members, they said, well, that's great. This is just too much. And we didn't even know that you had these dashboards and other things. So they've made a commitment to really think about how can we get data and these kinds of tools back into the hands of the community in a very friendly way so that they understand the data of their neighborhood as well as where the opportunities are to make impact. And I think that's been a very, very interesting perspective for another level of community engagement. They've developed an email sort of like call help desk where individuals from the community can call in and from organizations to make data requests and actually get it in a very friendly way and have it explained to them so that they can apply it within their agency or their neighborhood. I think that might be it, right? Do I have one more slide? That's my contact information, which Drew, you're happy to share out. And if anybody's interested, I could talk for hours, but I wanted to leave a few minutes for questions and comments.
I would love to actually initiate one comment or question, and that's from our team from New York. How do you, either Priti or I think it's maybe someone else, if you guys can, how do you see your focus on community wealth building and sustainability? How do you see that? Did you see an example of how that can work through what Amy has been saying in the last few minutes? Just trying to see if there's a connection there. I know in your slides, Amy, you talked a lot about financial well-being, you talked a lot about local businesses and things like that within these communities, and obviously having gainful employment of people who with lived experience who live in the communities that you're serving. I just wonder if there's any connection between that and some of the work that the state of New York is doing around community wealth building.
Drew, can you hear me?
I can.
Okay, great. This is Preeti from New York. As Amy was speaking, I was actually thinking the exact same question. I said, where is the connection? Where is the link? Because one of our partners who's going to do one of these equity labs is also going to be talking about community health workers. And so we're kind of one of the groups that the champion for that is the Democracy Collaborative, which works out of Cleveland, Ohio, and has been doing it since the 1970s, 81 miles from Mansfield. I was looking it up. What I think, this is what I was thinking, and I don't have the answer because the whole aspect, the whole part of community health building is actually it's focused on equity and making sure that the capitals, not only income, the social capital, all of that is shared in the community. And as I was thinking about community workers, you're right, Amy, they're really invaluable with their insights and how they can actually reach out to the community and make the work more relevant and everything. They also very often are, in terms of the pay scale, are often at the lower end of the department in terms of the hierarchy. And so in terms of community wealth building, as much as we look at the objectives, our health objectives of the people we are serving and the community health workers are serving, do we also look at the kind of well-being and resilience issues with the people who are serving the people we are serving? So let me give you an example. I was at a workshop, and one of the people who worked in a special needs facility for children said, we have a lot of care workers. They're very good. They have very good experiences that the people can relate to them. But she also said they also have issues and that they need to work through. And so she was asking us, how we can help them with the issue. So part of it is there a way for them to move up the hierarchy, in terms of bettering themselves? Is there, I know, for example, me at the health department, because now I'm a senior employee, I'm a professional, I have more flexibility in my work and what I do. So I guess that's what I'm going to ask you, Amy. I know our AIDS Institute here also uses community health workers, and they're working with certification. But really, how do you measure the well-being and resilient aspects of the workers?
So it's interesting because our goal for 2019, and this is my own as well as theirs, is this idea of self-care. So several ways. We meet monthly as a group with community health workers across the county, and we really build that as their time, what kinds of training. So not only are we working to help them maintain their certification with CEUs, we're also providing other educational opportunities to help them to broaden some of their experiences so that if they have an interest to move on and grow and develop other, pieces of their profession and maybe even move on and elevate, we want to be able to provide that support. So there's a deep commitment to that within our organization. I don't know how many of you are familiar with community action. That is definitely the community action model. We administer Head Start. So oftentimes we have families that come in as a Head Start parent, and then they become a teacher's assistant, and then we provide support and education to help them become a teacher and maybe a Head Start supervisor. So this whole model of maximum participation and efforts together are really what we're looking at in terms of community health workers. Our first goal has been to demonstrate the sustainability within these organizations, because for many of them, they're new positions, and to show the value in their efforts. The second piece is definitely, now that we've showed this value, how do we then match that up with the money that they're being paid or additional incentives? Because ultimately their work is saving all of these organizations and the systems that they're within. So we're looking at a large scale cost benefit analysis that really showcases and highlights what they're doing. But there's obviously work to do, because a lot of these issues then build into equity. Most of our workforce is very diverse. So that leads to another whole conversation about what's the value in these kinds of positions, as well as within, the ladder of hierarchy within organizations based on education, based on experience. And I know that we've had conversations across our agencies about livable wage and what they're being paid. And so that's another level of, I'd say, conversation and change that is hopefully going to happen this year as well. So really great points, and definitely something that we're considering, because it's one thing to provide jobs and develop economic, development in particular neighborhoods. It's another thing to make them livable so that people are feeling progress, and that, is a deep connection to their health and well-being.
Thank you, Amy.
Amy, this is Kathy Vazina. Here in Maine, we have a fairly robust group of community health workers that are working for a few different places, but really our challenge is that right now in our settings, there's just really is very little reimbursement mechanisms for community health workers. I know there's discussion going on here about trying to do something on a policy level that can enable expansion of services through Medicaid, Maine Care. But I'm interested in any thoughts that you have around ways of improving reimbursement for these services.
So currently in Ohio, we're a Medicaid managed care state, and we have Medicaid expansion. So we have with our project, 4 of our 5 Medicaid managed care companies have contracts with our hub. Mm-hmm. And what they're paying for are all value-based, outcome-based services. So delivery of a healthy baby, housing for a certain number of months. And I'd be happy to share what those outcomes are. So within the state of Ohio and even other hubs nationally that are coming up, we've developed, or I should say the model designers developed standardized payment codes that are outside of like what a hospital or maybe a health department would bill for Medicaid. And while they're, it's Medicaid money, it's more their administrative dollars, like what they get for meeting their quality measures or their HEDIS funds. So we've done a lot of work to have conversations about, we can help you, reduce, let's pretend, reduce readmission rate if you have adults with chronic disease. We can help you improve that first well baby visit, because that we know is a HEDIS measure. And if you get babies immunized, then you all get extra dollars from the feds when you meet these particular measures. So I think being able to show some of that, I'm not in my office, but Buckeye Health Plan, which is Centene Corporation, I don't know if anybody's familiar, they just did a huge return on investment looking at these particular markers within the Pathways model with one of the hubs in Ohio and demonstrated the return on investment. I think, it's one thing to have a conversation and say, we should do this. It feels good to reimburse community health workers. At the end of the day, they want to see how it's going to impact their bottom line. And, for the investment that they're making, how does that improve the health of the community? So I can happily share that. There's several papers and journal articles that have demonstrated that. And maybe that's a talking point to show that value.
Yeah. Great. Thank you.
Drew, you're on mute.
Talking away.
Oh, thank you so much. I feel like now maybe you should have just, I should have had more faith in you and waited to do the survey after you spoke. Probably get hired.
Yeah.
I was trying to
That's
stall.
all right.
I was like, what can I do now to stall? So I'm sorry about that. But that's okay. That's okay. We have so many comments right now in the chat about how informative this has been. So I really appreciate it. And I hope to have you maybe help me out with an office hour next week. Oh no, you'll be not around next week either. We'll figure it out. Because I'm sure there's more.
Yeah, absolutely.
People want to know.
And I'm happy to send, resources to you. And even, the developers of the model are extremely helpful to talk to. And I know it's a different way of thinking about the world, right? Most grants have deliverables and outputs. And so to begin to think about it from a social determinants outcome perspective, it's exciting. It's also challenging and uncomfortable too. And I definitely recognize that we have had tremendous growing pains, and I'm always happy to share what that looks like too.
Thank you so much. And if you're on chat right now, please quickly read what Fran just wrote. And I think that is a mindset, and that's hopefully what we hope to see when we're doing our equity action labs. That some of our goals will have more of an asset-based, more meaningful and simple. So yeah, thank you, Fran, for that. That's fantastic. All right, Chelsea, it's all yours to close us out.
I was on mute. Thanks, Drew. So we're going to end as normally with asks and offers. So please feel free to type into the chat. What questions do you have? Do you have any asks for the group? And is there anything that you would like to extend as an offer? And we're going to give everyone about a minute to chat in, just kind of where they're at and if there's anything that is needed. And I'm already seeing some great thank yous to Amy. And Rumana is presenting about sustainable payment for CHWs, reimbursement and alternative payment, taking place on a national scale at APHA, and she can offer resources if needed. And since we are a smaller group, you can also feel free to chat out any comments.
Sorry, Chelsea. I meant that we did present research about community health workers, their payment on a national scale among community-based payer and provider settings. We presented in 2015, 2016, and 2017, and the previous year we presented on implementation science frameworks as well. So if anyone wants more resources on a national scale about what's going on besides what Amy said, which was very informative, thank you for that. I'm happy to provide any resources on it.
Thank you, Ramona, for sharing. We have a message from Preeti that there was a lot of content covered and that they're just in the beginning of setting up a process for collecting information about community wealth and resilience building, and that they'll share more once it has been tested. So that's exciting to hear, and we're looking forward to you sharing then. And if anyone else has any other questions or asks and offers, please also feel free to email us, and we'll be sure to mention it and shout it out during our next call. If you'd like to go to the next slide. Our next call is on solving measurement and system change issues. It'll be special topic call number 4, and that's going to be January 31st from 10:30 to noon. Thank you all for joining us today, and please let us know if you have any questions.
Thanks, everyone.
Thank you.
Thanks to our speakers.
Thank you.
Thanks, everyone.
Bye, everyone.
Bye-bye.